Hi everybody, this side Dr. Mayank Nilay. I am Assistant Professor and Chief Consultant at the Medical Genetics Department of Postgraduate Institute of Child Health, Noida. I deal with rare disease patients and I am involved in seeing the genetic disorders and their management as well as diagnosis. Today I'll be discussing an article which was published in the Journal of Inherited Metabolic Diseases in the year 2020. This was a multi-centric study involving 10 collaborating centers from India who are involved in managing patients with Fabry disease. And the first author was Sheela Namboothri. It was a big group. So basically, Sheela Namboothri et al., Journal of Inherited Metabolic Diseases in July 2020. So a little bit about Fabry disease. Fabry disease is an X-linked recessive disorder, and it is caused due to a mutation in the GLA gene, and the enzyme deficit is alpha galactosidase A. Basically, this is a lysosomal storage disorder, and due to the deficiency of the enzyme, there are accumulation of metabolites like globotriaosylceramide and lyso-Gb3. The prevalence of Fabry disease has been reported between 1 in 40,000 to 1,17,000 population worldwide. Regarding the gene, GLA gene, it has 7 exons. It is located on chromosome XQ22 location. In this study, multicentric study, 54 patients were enrolled, and this was a retrospective study in which patient data was retrospectively analyzed from 2007 to 2019. Genetic testing was also done for the patients, and 49 patients had a genetic mutation, so the diagnostic yield was around 91%. Most of the patients, the mutation was detected in the GLA gene. Also, a detailed phenotype has been explained for most of these patients in this study, and their genotype-phenotype correlation has also been tried. The most common clinical manifestation in Fabry disease patients in this study was the renal dysfunction, which was seen in around 70% of patients. After that, the typical neuropathic pain was seen in 63% of patients, which is also quite common in the classical phenotype. Many children present with burning pain, acroparesthesia, also growing pain, growing age bone pain. Most of the time it is misdiagnosed like that. After this common presentation, the other common presentation seen was left ventricular hypertrophy, which was seen in around 45% of patients. And those having a late presentation, stroke was also seen, which was seen in around 9% of the patients. The most interesting part was that the average age of onset of symptoms was something around 14 years plus minus 7 years, while the average age of diagnosis was around 23-24 years plus minus 8 years. So you can see there was a gross delay of around 12 years from the onset of symptoms to the diagnosis. Regarding the clinical phenotype, as we all know, Fabry disease may have a classical presentation and a non-classical presentation. The classical presentation, generally the age of onset of symptoms in various studies has been between 3 to 10 years of age, and generally these children present with pain, neuropathic pain, hypohidrosis can be a presentation. Sometimes they have a gastrointestinal manifestations like postprandial diarrhea, weight loss and all can be there. And in the late presentation, generally it may present in 3rd to 4th decade with a stroke. Either it may present as a recurrent stroke or sometimes just as a headache, vertigo, even transient ischemic attacks, and even ischemic strokes have been reported. Regarding the cardiac involvement, left ventricular hypertrophy, even arrhythmias have been reported. So the most important thing which we told initially, that the most common manifestation was a renal dysfunction, which has been reported in studies from other parts of the world as well. So most common presentation in the renal dysfunction can be a microscopic albuminuria or a significant proteinuria. Gradually that may progress to a renal dysfunction, which was also seen in the cohort of patients published in this study. Lyso-Gb3 is a good biomarker to study the response of treatment in these patients, and also for as a part of the newborn screening and screening of such patients. Lyso-Gb3 level is elevated and generally level more than 1.3 nanomoles has been considered positive. The other important thing which this study told was about the cascade screening or the family screening. So as it is a genetic disorder, there are chances other members of the family may be affected. And surprisingly, in this study, around 19 patients were identified from 12 index cases by a family screening. Why family screening is important in a disease like Fabry disease is that most of these patients have a heterogeneity of clinical presentations. They may be quite normal for certain years, and in the second or third decade, they may present with renal dysfunction or cardiac involvement. So an early diagnosis will surely going to help them, because ERT can be initiated. That is the enzyme replacement therapy. One more important thing regarding Fabry disease is the involvement of heterozygous females because of skewed X inactivation, and that's why female heterozygous carriers with mutation in GLA gene should be closely followed up to detect any features of the renal dysfunction or cardiac features or other things related to Fabry disease. Dried blood spot is of course very important because it helps in the diagnosis and an easy screening tool. And the best will be the measurement of the enzyme in leukocytes. In untreated patients with Fabry disease, that's a very interesting data. The average life expectancy decreases by 20 years in males and 10 years in females. This is very important. So time again, I'm focusing more on an early diagnosis and early screening, which was also proposed in this article. Apart from the common features of renal dysfunction and this renal dysfunction followed by this cardiac involvement and stroke, some other clinical features which were seen in this cohort was angiokeratoma, which are the typical skin changes in the bathing area and in the umbilicus, bathing trunk area and in the umbilicus. This was seen in around 50% of patients. Apart from angiokeratoma, the typical changes in eye, which included cornea verticillata, which is diagnosed by slit lamp microscopy, was also seen in around 40% of the patients. Around 34% of the patients also reported to have a hearing loss. Hypohidrosis, which is a common manifestation in the classical type, was seen in around 33 to 34% of the patients, while gastrointestinal manifestations were seen in around 43% of patients. And in this study, postprandial diarrhea and urgency to defecate was a common finding. Now coming to the genotype-phenotype correlation, while in the genetic test, in this large cohort of 49 patients who got tested out of the 54, no clear-cut hotspot was seen. Mutations were found in all the 7 exons of GLA. Most of the families had a private mutation, so a typical recurrent mutation for the Indian subcontinent was not identified. Most of the common mutations were single nucleotide variants and included missense mutations followed by nonsense and frameshift mutations. One interesting thing which this study detected regarding the genotype-phenotype correlation was the early presentation and more severe phenotype in those having a nonsense mutation or a frameshift mutation, while those having a missense mutation, generally they had a late age of onset. Also in this study, it was found that neuropathic pain responded well to carbamazepine and gabapentin, while NSAID should be avoided because it may exacerbate the renal dysfunction. For stroke, a combination of enteric-coated aspirin, clopidogrel can be tried. For initiation of ERT, this is also very important. Since 2007, around 52% of the patient in this cohort had the chance of getting an enzyme replacement therapy. At present in India, enzyme replacement therapy, 2 types of ERTs are available. One is Replagal, that is given at the rate of 0.2 milligram per kg bi-weekly. Another one is Fabrazyme, which is given at the rate of 1 milligram per kg bi-weekly. Some of the patients were getting Replagal, while some of them were able to get that Fabrazyme. Regarding the comparative efficiency, like both of the medication were seen to have a similar course of action. They basically decrease the progression of the disease. While especially in cardiac patients, any left ventricular wall thickness more than 12 mm should be given an option of starting the enzyme replacement therapy. When we go on the proposed guidelines, they recommend any male child having a feature of Fabry disease or diagnosed with Fabry disease more than 16 years of age should be given an option of ERT. Apart from that, those children with classical severe manifestation, the classical phenotype, those male children around 8 to 10 years of age should be started on ERT. For females, any female who develops a progressive organ damage in the renal, cardiac, or any such other systemic involvement, they should also be given an option of starting the ERT. In this study, the average age of initiation of ERT was 27 years of age. important thing in this study was that around the 17% of those detected by familial screening, they were having features of the disease, while rest were not having the typical features. So again, this early finding through a genetic testing or a cascade family screening help in identifying those individuals who had a subtle features. Also, the most common misdiagnosis which is being made in a child with Fabry disease, that was also studied in this manuscript, and they found that most commonly it has been misdiagnosed as systemic lupus erythematosus, many times as chronic fatigue syndrome, even in some cases it was diagnosed as a hypochondriasis or a functional disorder, and some children it was considered as a growing bone pain. So this is also very important that a misdiagnosis should be avoided, and that's why awareness about this disorder is very important, because enzyme replacement therapy is also available, and if initiated early, it has shown that the progression of the symptoms decreases and these children almost have a normal life and their quality of life also improves. The major limitation of this study that it is a retrospective study, and the proper documentation of the response to ERT therapy was not better available, but still this was the first study from India with such a large cohort of patients, and it's surely added to the genotype and phenotype of Fabry disease in Indian patients, and will help in further prospective studies to see the response of patients with Fabry disease to ERT, as well as an early diagnosis is very important, which was the main gist from this study. And also the family screening is very important because of the heterogeneity of the presentations. Thank you.